So thanks for attending Bite-Sized Teaching today. This is going to be a quick recap of neonatal thrombocytopenia. And this was one of the suggested topics that might be helpful for the junior members of the team. Tim's done an excellent talk on Planet 2 and thrombocytopenia. So if you want to refer to that, that has lots of references to current research, and this is more of a practical guide. So what I'm going to cover today is the etiology of thrombocytopenia. I'm going to go over some of the key investigations that are useful to perform when you have a diagnosis of thrombocytopenia, how we treat it, and then hopefully if we have time, I'll go through a couple of cases of thrombocytopenia that you might see on NICU. So thrombocytopenia is actually very common in neonatal intensive care. It is more commonly seen in preterm neonates and less commonly seen in term babies. It can sometimes be related to immune causes or sepsis, so those are important causes to keep at the back of your mind. And also rarer causes can also cause persistent thrombocytopenia that we also need to think about. And these are usually due to production defects. So thrombocytopenia is defined as a platelet count of less than 150. And what we most commonly see on the neonatal unit are counts of probably moderate, within the moderate and severe category. So moderate, which is 50 to 100, and severe, which is less than 50. And these have historically been based on clinical experience of an increased frequency of bleeding, and previous research has shown that babies, even with platelet count levels of 20, have not developed any major hemorrhage, and these have formed the basis of some of the current research trials, including the Planet studies. So thrombocytopenia is very commonly seen, and of all those admitted to NICU, up to 35% might have thrombocytopenia, and up to 5% of all newborns might present with a low platelet count. It's increasing, its prevalence is increased in those of a low birth weight, and especially babies who are more premature. I'd like people to join in now and chip in with a couple of causes of thrombocytopenia that you can think of. So feel free just to unmute yourself and shout out a few causes. I mentioned a few earlier. Sepsis, yeah. Yeah.
ITP?
ITP, yes.
Someone in the chat says maternal autoimmune.
Yes. So that would be the same as ITP. So I've got quite a comprehensive table here, and you don't need to memorize every single cause there, but it sort of shows you how many different causes there are of neonatal thrombocytopenia, and they're basically grouped into sepsis, placental insufficiency or hypoxia, such as PET, and preeclampsia. Other immune causes, as someone mentioned, alloimmune causes, maternal ITP, and of course the rarer causes or consumptive disorders such as Kasabach-Merritt syndrome. So I'm going to split it up, and the Evelina NICU guidelines splits it up into preterm and term causes, as well as early and late presentation of thrombocytopenia. So this makes it easier to think of the different causes. So early is defined as with less than 72 hours of age, or within the first 3 days of life. And in a preterm infant, these are usually due to antenatal factors, such as placental insufficiency or fetal hypoxia that you might see in preeclampsia or IUGR. And this is usually self-limiting, and it resolves on its own without any need to do anything further. And what we usually do is just monitor the platelet count. Late thrombocytopenia, which presents at greater than 72 hours of age, is usually due to postnatally acquired infections, primarily bacterial infections, NEC, and other infections also including fungal and congenital infections such as CMV and toxoplasmosis. It's important in these cases to treat the underlying cause because the thrombocytopenia will then resolve, and whilst that process is happening, we provide supportive care and we monitor the platelet count closely. In term infants, low platelet counts are usually more rare. They're usually due to autoimmune causes, and the most important thing to exclude is neonatal alloimmune thrombocytopenia, also called NATE. The other causes include maternal ITP, infection, HIE, and rarer causes such as Fanconi, TAR syndrome, and other sequestration disorders such as splenic sequestration and Kasbeck-Merritt syndrome. So in the guideline, the etiology has been split up into early and late causes of thrombocytopenia, and here it's split up into mild, moderate, and severe thrombocytopenia with platelet counts listed, as you can see on the screen. So in the preterm infant with moderate thrombocytopenia, because there are increased risk of bleeding, a clotting profile is usually recommended. And if you have severe thrombocytopenia with a platelet count of less than 50, then you would need to exclude other causes of the thrombocytopenia. So excluding sepsis, abdominal X-ray to exclude NEC, and sending blood to hematology to check for innate syndrome. In late causes of thrombocytopenia, you always need to exclude sepsis as your primary cause. So that would include a septic screen, especially when you have evidence of other causes, other manifestations of sepsis. And in severe thrombocytopenia, you would also need to include further investigations such as a clotting profile, a possible screen for congenital infections, and you would also need to consider immune and rarer causes of the thrombocytopenia. So the mainstay of treatment for thrombocytopenia are platelet transfusions, but before you do this, it's always important to assess whether or not there's any acute bleeding, and the important systems of bleeding that you need to exclude bleeding in are intraventricular hemorrhage, pulmonary hemorrhage, bleeding from the GI tract or renal tract, and you need to assess the baby to see if there are any petechiae as well. So if the platelet counts are if the platelet counts are less than 50 with moderate, severe, or major bleeding, then they would need a platelet transfusion. In preterm babies, this threshold is at less than 25 if there's no bleeding or minor bleeding, and this is in line with the results from the Planet 2 trial. And in the term infant with no bleeding or no minor bleeding, the threshold for platelet transfusion is less than 20. If there are concerns about neonatal alloimmune thrombocytopenia, then you should always seek senior and hematology input, and this would definitely be necessary before you treat with HPA-1a negative platelets. And following discussion with senior members of the team and hematology, if there's ongoing consumption of platelets, then IVIG can be considered. It is only when platelet counts are very severely low, at less than 20 in the context of maternal ITP or NATE, that you would consider platelet transfusion. And all of this is listed in the guidelines, so you can look it up as needed. In terms of prophylactic platelet transfusions, at the moment, our guideline states that if that your platelet count should be at least 50 for a lumbar puncture. And if a baby is going to theatre for a procedure, then the platelet count should be at least 100, although it's always useful to discuss this with the anaesthetist and surgeon, as each case is different. And it's also, it would also be prudent to have some platelets available in theatre as a backup. Prophylactic platelet transfusions are not currently indicated for long line insertion or if you're treating a baby with ibuprofen for PDA, although each case needs to be assessed separately. In the term infant, like I mentioned earlier, I've done this. This is a repeated slide, sorry. So now I'm going to go through some cases, if that's okay. How are we doing on time? Yeah, okay. So just quickly, this is a case of a premature infant. That's 25 plus 6 weeks gestation. It was an elective section for maternal reasons, low birth weight, started on TPN. The initial platelet count was 80, and then had features of NEC on day 10. And then on day 10, platelets were 47, which then dropped to 22 12 hours later. Blood test showed DIC, and baby improved clinically with blood products, antibiotics, and bowel rest. What do you think the causes of the low platelets could have been here in this case? Just shout out because we don't have much time left.
NEC?
Yes.
DIC.
So I think here we have two things going on. So in the early period, due to maternal factors, the platelet count was on the lower side, and this could potentially have been due to some of the medications mom may have been on. But primarily the lowest platelet counts were when baby was over 72 hours of age. So baby was 10 days old at that point, and baby had a postnatally acquired infection, which was NEC. And this resolved itself with supportive care, blood products, and close monitoring. Now I have another case which involves a term infant. So this was a term infant born by emergency section for reduced fetal movements and fetal bradycardia. It's hypotonic at birth, was not breathing spontaneously, needed resuscitation, had seizures at 30 minutes of age, and treated with antiepileptics, and head scan showed grade 3 IVH bilaterally. And the initial platelet count was low, which fell to a lowest nadir of 52. What are you thinking here? What could the cause of the low platelets be in this case?
HIV, hypoxia.
Yeah, hypoxia. So here we have quite an unusual presentation of a term baby with bilateral IVH and early onset seizures. Whilst HIE is also one of the more common differentials that you would think of, it's also important to exclude NATE, so neonatal alloimmune thrombocytopenia. And this is usually caused by maternal antibodies crossing the placenta, targeting platelet antibodies inherited from dad. And these are associated with intracranial hemorrhage, which has a very poor neurodevelopmental outcome. And other causes you would also need to think about are maternal ITP or SLE, although this usually causes less severe thrombocytopenia. And then other causes of thrombocytopenia also need to be excluded, and these hematology would guide us to exclude these, but they would include things like Wiskott-Aldrich syndrome, which causes immunodeficiency and eczema. Okay, so thanks very much for listening.